Hi, everyone. Good evening. We'll kick off. Thank you for joining us. Thank you for your interest in the master's program. My name is Kash Akhtar. The chap you can see who's been kidnapped in that shipping container is Peter Bates. That's where he lives. Times are hard. If you get to the bottom of the screen, there's a chat box, so please feel free to ask us any questions. Anything that comes up. I'm going to share some slides and we'll chat to you guys about our master's program and just explain how it works. So the Orthopaedic Trauma Science MSc is delivered online. Peter and I are the course directors. We have lots of our colleagues from Barts Health NHS Trust and across the region who help deliver some of the content, some of the lectures and the tutorials. And essentially the way it works is that all the content is available online, a bit like Netflix. It's there. You can watch it wherever you want, whenever you want. And those are the lectures. And then we have tutorials on a Thursday evening. The tutorials are live and interactive, very similar to this. And there's a lot of back and forth. And then the tutorials are recorded. At the end of each module, there's an assessment, which we'll come back to. So Pete, these are yours.
Hi guys, welcome to this little introductory soiree between Kash and I. Just want to talk to you about who we are, really, who we are, what we do. Kash Akhtar, who's Kash? So if you Google Kash Akhtar, this slide's a little bit old, maybe like it's 9 months old, but if you Google Kash Akhtar, orthopaedics, this is kind of what comes up. What have we got there? We got, so obviously he's a top surgeon these days at the Cleveland Clinic. So lots of pictures of him in a suit with hair that he doesn't have anymore.
I've updated it now. There's some ones now with no hair.
Oh, okay, that's better. That's more true to form. Give me the next slide.
Oh.
This is the thing about Kash. You see, he loves a bit of confectionery. He loves, and that's been a lifelong thing. Just confectionery, fizzy drinks. There's always, whenever you see him in a tutorial or in any kind of clinical or non-clinical situation, there's always a can of pop not far away. That's one of the features of him. What else have we got? He and I run a podcast together called See One Do One, and there's the various episodes, the whole bunch of them now. But it's really quite worth listening to. So whether you come on this MSc or not, dip your toe into that one and see how you get on. It's quite some interesting orthopedic but kind of fun podcast. Bit of a laugh, bit of a jock around.
The thing that's interesting about the podcast is it's been downloaded in 114 countries now, 114.
Ooh, 114.
But the basis of all this are MSc tutorials.
How many countries do you reckon you could name if I just put you on the spot right now?
Like 40.
We're not going to do it because it would just be too boring. But
40.
You reckon you do 40?
Yeah, I can do much more than that.
I'd be drawing up by 35, I think.
Yeah, and the one thing I would say is, so the podcast is very much based on our MSc tutorials. In fact, that's exactly where the idea came from. The MSc tutorial is a lot more interactive, a lot more case-based discussion. So the podcast is basically a light version of the tutorials. What's next?
Oh, Pete Bates. Yeah.
Pete
so
Bates.
if you Google me, it's a different story. There's a few of me, but mainly it's other people. It's mainly other people around the world called Pete Bates. There are not very many Kash Akhtar's orthopedics who hit the front line, but Pete Bates orthopedics definitely hit the front line. Yeah, this guy's my favorite from the Methodist Church somewhere in Ireland. Yeah, he's my favorite. He looks like he likes a gin and tonic, doesn't he? Who else we got? Oh, there we go. Yeah, that was at some fancy dress party. I think that was an AO course about 4 years ago.
Keeping it patriotic, and there's you as well.
Oh, that was at Disneyland. Yeah, that was when we took the kids to Disneyland once, and then you know when you're having breakfast and you're a little bit hungover and you're just sitting there just trying to enjoy your breakfast. You're a bit tired and looking forward to having to trounce around Disneyland all day, and suddenly Tigger comes up and is all happy and
You can't help but smile, can you?
Yeah, that's right. You can't help but smile. Exactly. Yeah. So welcome all. Welcome to our podcast. Not to our podcast, to our MSc. This is really just to get a feel for Kash and me and give you an idea of whether you think this kind of fits for you or not. Kash.
So I'm going to give you an overview of the masters. The way it works is, as I mentioned earlier, it's all delivered online. The Lectures are available for you to view on any internet connected device, be it a tablet, a phone, or a computer. The lectures are available, and then at the end of each one there's an assessment that I'll come to. So these are the modules that we do. There's Trauma the Disease, which basically talks about trauma systems, trauma networks, trauma units, pre-hospital care, and then what happens in the emergency department. There's hemorrhage and response to injury. These two are, you'll be joining our colleagues in the Trauma Science MSc for those two modules. And the hemorrhage and response to injury very much is how do we manage bleeding, how do we manage coagulation and clotting, and how do we really manage that initial hit. We've now moved the research methods to the second year, so I'll come back to that one. If we scroll down a little bit, trauma to the pelvis and torso, that we do just before Christmas, and that is Pete's baby. That's where we're talking about a little bit about chest injuries. You want to know a little bit about blunt trauma, hemopneumothoraces, these kind of things, but the bulk of it is talking about pelvic and acetabular fractures, classifications, how to manage it from a resuscitation point of view in resus, how to manage it surgically as an emergency, and then approaches to fixing pelvic and acetabular surgeries, surgical approaches, fixation techniques and methods, and that's all backed up with the tutorials on a weekly basis. Pete, do you want to add anything to that module, your pelvis module?
No, I don't think so. It's kind of, I guess the pelvis one and also the chest to a certain extent and torso. It's about all that stuff about resuscitation being put into context of the injury itself. So you're learning the theory behind resuscitation in one of them, and then you come into the kind of practicalities of then what do you do with the pelvis? How do you fix a pelvis? How do you, where do the nuts and bolts go? All that kind of stuff.
Thank you. After Christmas, we have spine, spinal cord, and nerve injuries, and that's really good. So basically, there's a little bit about head injury. The bulk of it is what happens if there's a bony fracture, what happens if there's a spinal cord injury, and then we go from there to the plexus and work our way peripherally all the way down to the peripheral nerves. We cover all aspects of that, and that's really, really useful for your on-calls and for any exams. Then we have a whole module on fracture biology and limb trauma. We talk about fracture healing, fracture classification, and then we talk about fractures all the way from kind of sternoclavicular joint, clavicle, all the way down to the fingertips. And then we go from the head of the proximal femur, femoral head even, all the way down to the toe. And so we talk about every fracture you will ever see and how to manage those. And that's a really popular module. And then we have, there's an optional module. So we have the ones that the vast majority of our people choose are open fractures and orthoplastic surgical care. Yeah. And that very much talks about how do you classify open fractures, how do you treat open fractures, what do you do in the pre-hospital setting, at the roadside, what do you do in the emergency department, what do you do in theatre. And then we talk about basically the fixation and management of those, and we talk about orthoplastics, and that will talk about things like, can you close it directly? Does it need a rotational flap? Does it need a regional flap? Or does it even need a free flap? And what are the principles of that? What makes you decide where you are on the surgical ladder and what you do? And we have a module on pediatric trauma and limb reconstruction. And that's a really good one because that talks about peds fractures, supracondylar humerus fractures, femoral fractures. When do you use a spiker? When do you put a nail on it? When do you plate it? These kind of things. And because pediatric trauma can result in deformity, we then segue in that module into limb reconstruction. And we talk about using external fixators, circular frames, hexapods, these kind of things. And how do we do that? We talk about osteotomies. We talk about some of the principles of osteotomies. And so there is, by the end of the masters, you've got a really solid understanding of the management of trauma, orthopedic trauma, from a very holistic point of view, not just how do you fix the bones. We do have a whole module on that. We have the optional summer school that I'll come to in a second. Then we have in year 2, we have the research methods, which is a whole module to teach you about how to read papers, how to critique and analyze papers, which we'll be doing all the way through anyway in the first year. But this is very much talking about how do you do a literature review, a systematic review, what different types of study are there. And that really sets you up to then in the year 2 to go on and to do your dissertation. The way we assess the modules is that this is kind of how the assessment works. There are MCQs. From a couple of the modules are marked by MCQ only, so that's the whole assessment. Some of them there's a module, there's a MCQ and an essay. And then the other thing that you'll see, and there's one, the pediatric trauma one is an interesting one, because that's basically a presentation of audio over slides. And so we give you guys the opportunity to do a PowerPoint presentation, just a 10-minute presentation with your slides, but you record a voiceover as if you were presenting on a podium in a conference or a regional meeting. And that will give you tips and pointers as to how to improve your presentation slides and techniques. And that's kind of a real life skill. But at the same point,
absolutely,
it gives you experience of how to critique and how to really bring out some nuance in your spoken word that you may not be able to do quite so well when you write it.
Totally different skills, those, writing an essay where basically you're trying to get every little detail down in a concise, like jammed in fashion, so that it but in a way that flows, so it's readable, but at the same time it's like boom, 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 and you're lining up all the facts, as opposed to a presentation where the challenge is more about holding people's attention. So holding people's attention and getting the most important things over, rather than cluttering up a slide with a whole load of facts that you might put in an essay, but you can't put in a presentation. So you've got to decide what goes in, what doesn't go in, etc. So yeah,
that's a real,
really complementary skills.
And it's a real life skill. It's a key skill for a medical career. And then at the end of the second year, there's a compulsory dissertation, which is a 3,500 word dissertation, which was 10,000 before. We brought it right down. And the reason we brought it down was because that's about the average length of a publication. And our aim is that you guys will go on to publish your dissertation as a paper. And then you will also then present it. And hopefully using these skills, you'll be able to present it as well. And we've had many publications over the last few years from the masters, and quite a few podium presentations as well. So we want you to leave with a master's degree, a publication, and a podium presentation at BOA, EFORT, ESCA, some of these big meetings. So this just gives you an overview of how the modules look. And so this is this current year, just to give you an idea. So basically in the autumn, from September to Christmas, there are 3 modules. And so we've paced them out. There used to be quite a harem scarum pace. Now there's 5 weeks for each module, and there's time to really digest, understand the content, and then take a whole extra week to focus on the assessment. So module 1 is trauma disease, and module 2, hemorrhage, and number 3 is pelvis and trauma. Then after Christmas, there's a 2-week break there. Semester 2, we cover module 4, which is spine and spinal cord injuries. Number 5, which is fracture biology and orthopedic, basically fractures anywhere. And then module 6 is pediatric and orthopedic trauma. There's then, we go straight into semester 3, which is module 7, which is your orthoplastics and open fractures. And then we have summer school. And summer school is a 2-week optional thing in London. So you don't get to meet us at summer school, and you don't have to come to summer school. But Pete, tell us about summer school.
Summer school is just the most, it really is, it feels like the coming together of the course in many respects. So it's not just orthopedic guys, it's the people doing the trauma sciences as well. So there's a slightly bigger group, but the whole of you, the orthopedic and the trauma sciences people, come together, and we all join up in for 2 weeks in London. It's like an action-packed kind of 2 weeks where every day there's something to do. There's a little joint project, but nothing too overwhelming. And on the orthopedic side, you get to do some really cool stuff. We do some sawbone things. We do lots of theory, but there's also a lot of we spend 2 days out in Watford at a cadaveric lab, where you get to like put plates and screws and things onto bones. You get to do operations, on cadavers. So you get to plate ankles, fix neck of femur, nail a femur, etc. All of that, and how to manage an open fracture. You get to do these things on a cadaver. So that's a nice thing for upcoming surgeons. And we also there's also a lot of like inspirational stuff, talking about how to manage failure, how to manage success, how to be a good leader, how to
choose a mentor,
trainer. Sorry, Cash.
I was saying choose a mentor. How to choose a mentor? You're talking.
Yeah, how to choose a mentor. That's the one. Yeah. So there's and also we talk about operating in austere circumstances. So operating in war zones, etc. And we get some proper experts who do that a lot to come down and talk. So it's a really cool 2 weeks where you get to do all sorts of, you get to see, each day is a wholly different experience. And then of course at night, you get to go and hang out with all of each other. And you, by the end of the 2 weeks, a real kind of bond has formed between all of you guys because you've all been hanging out together. And it's really nice. And the thing is, you've kind of got to know each other in the meantime through the online tutorials. So you sort of know each other, but you've never met. And this is the first time where everyone comes, oh, that's what you look like. And it's quite nice.
It's a really great coming together. It synthesizes everything you guys have done in the first year. It really makes it real and kind of brings it to life. And, you know, you get to meet all of us, but more importantly, you meet each other. It's very social. There's lots of events in the evenings, and you guys will be doing lots of your own things as well. Susanna Jones, just to give you some feedback, this is on the website. Susanna was a physiotherapist who came through, did a brilliant presentation, dissertation on trauma rehabilitation. And so this is her quote, that it gave her a renewed appreciation of pre-hospital and surgical patient journey and broadened her knowledge of orthopedic trauma. And she was not a doctor. I would say a lot of the people who do it are doctors, predominantly orthopedic surgeons in training of various degrees, but we've had physiotherapists, a few of them that come through, who've done really well. And the thing that it does, so Thanos was with us, and the thing that Thanos did really well is he ended up publishing and presenting, but he also ended up getting a training number. And so now he is an orthopedic registrar ST4 in Cambridge, east of England. And this is the thing that's really interesting here. This is a really nice quote, and I promise you, I didn't tell him what to write. He said the MSc enabled him to get a national training number. And the thing is, that's not what it's set up for, but it entirely does. And every tutorial could be an interview question or real life emergency that you can face. And so what every single question that I ever ask in a tutorial is based on a natural selection question. And anything that Pete ever does is something that you do in real life and something that will affect your daily practice. Pete.
Great. So I see there's only like 3 or 4 of you in the room. So I'm not going to, I think.
Should we leave this then?
Sorry?
Do you want to go through this, or should we leave it be?
No, I thought I would just do a very quick bit on this, but I'll whiz through it very quickly. But rather than asking questions of the guys online, because there's only 6 of them, it seems a bit, only 3 of them, 3 or 4 of them, so it seems a bit unfair to ask tons of questions. What I thought I would do is I'm just going to give you a flavour of 5 minutes of what a tutorial might look like. Okay. So it would start off something like this. We would, and this is usually how I run my tutorials. It start off by describing a patient. You say, I've got a 28-year-old male schizophrenic, and you give you a little bit of history. And the next slide, I don't think I can advance from here, can I? Yeah. Okay. And then we talk about his obvious injuries and his current hemodynamic status. And you can see from that, his pulse is high, blood pressure is low. He's obviously shocked, and obviously we're by the roadside, so we don't really know yet, but his chest looks bad, head looks bad, pelvis looks bad, and looks like he's probably got a femur fracture, and he's got open injuries to both feet. So this is, and then he comes in and he has his first like chest x-ray and pelvic x-ray, and that's what it looks like. So it's that thing of like, what do you do now? Where do we go from here? How do we organize our thoughts around this guy? And that's really what the course and the tutorials are about. Is okay, you've got ATLS, fine, and that's your sort of baseline, if you like. But it's the higher order thinking above ATLS that we're then pushing into, particularly on the orthopedic side. Next slide.
And the way the tutorials run is that obviously we're just giving you a very quick run through. This is very much interactive. And at every single stage is, what are your thoughts? What would you do? How do you classify this? How do you manage this? And it is very much a back and forth interaction. So it's very, very conversational.
Very two-way. Yeah, absolutely. And it's right. So we try and get you guys involved. So we talk about all the various injuries, and then you keep scrolling forwards. And he's obviously got a bad chest as well. You can see there's a chest drain in on the right side. And you know, what are the things going through your mind? And we talk about what are the things that you want to be doing now? What are the sort of immediate things that you want to be getting stuck into? And those would be things like arranging your trauma team, you know, getting prepared, getting sorted out, putting in any chest drains and lines and stuff, and getting your monitoring going, checking the breathing and airway. And then you're into C, and C is quite a big deal, even in orthopedics. because you want to get a binder on. Often that happens pre-hospital. You want to get your massive transfusion protocol going, and we talk much more about that, about the constituents of it, what it consists of, and what each element has to play within that. You want to keep them warm. You want to keep their blood pressure down a little bit. You don't want to get it too high, or else you'll blow up a clot. But if it goes too low, then your brain won't get confused, and then you've got a problem there. And of course, tranexamic acid. And we talk about the crash studies. People talk about crash 2, but there's a crash 1 and there's a crash 3 as well, which we could talk about what each one of those showed and what the latest evidence around tranexamic is. And then, of course, if they've got an open injury, then we want some antibiotics. A is for antibiotics, as opposed to ABC, as opposed to airway. It's a terrible joke. Roll of fast and CT, traction splints. Should we put traction on or not? And we can discuss each one of those elements within the little group as we slowly start building up our picture of how this treatment would go. What's next? So that's where we are. Next one, that's there. So we start doing our massive transfusion protocol, and and next one, and our things start improving. We start getting a better blood pressure. We start getting a pulse starts coming down a bit. The lactate starts improving a bit. Low lactate is good, and then fast negative, which is good news. So is it safe to go to the CT? And that's one of those questions that we used to have a lot. Is it safe to take this patient to the CT scan, or are they too sick to get a CT? But nowadays, CTs tend to be sat in the resus bay, and we've got these things called level 1 infusers. This particular one's called a Belmont, but there are various designs. And those can pump in blood very, very quickly, which gives you the confidence to get in and out of the CT scan, in and out of the interventional radiology suite, or wherever it is you need to go. And of course, it's a contrast CT. It's not just the CT, it's a contrast CT. So you can look at where bleeding's coming from. And then that then takes you to the other place and say, well, if you've got a bleeder there, if his spleen is bleeding, can I embolize it, or do I have to take it out? Does his pelvis need packing? Does his liver need packing? Does his, or has he got something in his pelvis that I might be able to embolize? In which case we can go after that. So the CT brings a huge amount of information, as well as whether you've got a head injury and what's going on in your chest and your spine and all the rest of it. And then, having gone through all those like non-orthopedic kind of things, now we're into the order of, how do we marshal our thoughts orthopedically speaking? Because there's a pelvis, there's a femur, there's bilateral open calcaneal fractures. But let's say the abdomen and the head are, I say they're okay, they're being treated non-operatively. So it's kind of down to us now. It's now orthopedic problems. What are we going to do? And so we talk about what the order of priorities would be after that. And by stringing it out like that, and by discussing each bit slowly but surely, we can explore each individual element. So here, for example, we discuss about the role of a binder. I'll miss out the rest of those. But if you go on to the next slide, we talk about binders work. We could talk about when to leave them on, when to take them off, how long they need to stay on for, how what the evidence is behind them, etc., etc. So I'm probably going to stop there because I think that gives you a feel of where we're going with these tutorials and how the discussion would flow.
So that gives you guys kind of an idea of the kind of things that we would discuss, and just a flavour of the course. Do you have any questions for us? Because we're here to answer your questions. So please feel free to answer any questions. You can turn on your mic and video and talk, or you can type in the chat box, whatever you guys like, but we're here to answer your questions.
There's always that ominous silence.
Yeah. I hope you guys can. This is when you find out no one can hear.
Type something, anything. Say, thanks for that, or just type something, just so we know.
Hello. Even a hello would do.
Even a hello would just would enrich my life.
Either, or we've both been on mute for the last 30 minutes.
Yeah, just shouting at each other.
It could be slightly awkward.
It wouldn't be the first time.
So, Chris, can you just confirm to everyone the deadline for applications, please? Thank you, Kabir. Appreciate it.
Cheers, Kabir. Thanks.
No problem. The deadline we usually go with is the 31st of August, just because it can take some time to go through the process of the admission, the application process, and then enrolment and things like that, and checking of paperwork. So the Blizzard might end up like giving a later date, but basically if you apply after the 31st, you're very unlikely to be able to start in that first week. You're going to probably miss the first week, unfortunately. So sooner the better, as with everything.
That's the one thing I would say to you guys. So the deadline is 31st of August for applications, but if you're going to apply, which I hope you will, and you get to meet us and talk to us regularly, I would encourage you to apply as soon as possible, just because sometimes there can be some back and forth. If you are overseas, for instance, they may need some further paperwork that you may need to obtain from somewhere. And Victoria, suitable for nurses. So we've had quite a few nurses go through, Victoria. We had, I mentioned Samantha as the physio there. We've had about 3 or 4 orthopedic trauma nurses come through. We've had some nurses from Christabel and a few others from Malta, and they've all come through, and it is, and they've done very well. So no orthopedic nurse has ever started the course and not finished it and graduated. They've not left the course early, so they've seen it through. I know that a lot of the stuff we're talking about does seem quite more kind of, clinician based there, as it were, doctor based, but that's not the case.
It's really not. And we also do modify this discussions to include nursing, physiotherapy expertise when we're talking about these things. Because actually, it's true, we do have different considerations. The nurses and the doctors and the physios and the paramedics, everyone has a slightly different take on the situation. And I think it's really helpful, and we've really valued having other disciplines in the room so that we can have a more rounded discussion about all these things. So it's not just about didactic one line of thought. It's about including all the different elements, and some of the richest discussions we've had have been included the nurses, the paramedics, the physios.
It was because Lisa Andrews was another orthopedic nurse who joined us. She came to summer school and she absolutely loved it.
Yeah, she absolutely loved it.
And so the thing is that from an academic point of view, there's not been any issue there at all. So they've all completed the course, graduated the masters, and so that's not the concern. Thank you, Olu. Tom, tutorials. So tutorials are delivered online. They are very much interactive. They are very much back and forth. It's not a one-way transmission of facts like this. They are very much, it'd be, so this is a case, exactly as Pete did. What are you thinking? What are your thoughts? What imaging do you want? Is that imaging satisfactory? Is it appropriate? Do you want some more? Are there any further tests? Any bloods you want? And we kind of go through in that sense and to develop the whole scenario, to talk along up to the positioning of the patient, the definitive management, be it surgical or not, be it percutaneous, open, minimally invasive. And the tutorials are every Thursday, 7:30 on, it varies slightly for module, but the vast majority is 7:30 to 8:30 on a Thursday evening. They are done online and they are recorded. So if you can't make it live, they're there. We normally have 3 per module. Kabir, what's your training most important for the starting? So Kabir, I'd say we don't. So I recommend people don't do it as an F1, but I'd say if you ask me what's the most common stage, it's probably F2, ST1, ST2, CT1, CT2 equivalent. We've had a couple of registrars come through. We've had a funnier registrar, but I'd say the vast majority are very much at an F2 to CT level when it comes to doctors. And so I encourage people not to F1. I think you've just got enough going on F1, it's busy, but F2 starting core training in August, you're in an absolutely perfect position. The nice thing is it gives you 2 years. By the time you finish your the MSc, you'll have it. You may even have got it published in time for national selection. But the main thing will be that you'll have done all the tutorials and you'll be absolutely ready and primed for selection.
True. Yeah, scenarios. Very, very well prepared.
Because we talk about clinical knowledge, clinical anatomy, prioritization, things that you wouldn't think of that, which are a really big deal.
Cash, is it worth talking about the MSc SHO program or not?
We can do. There are people who, the other thing that we do run is that there are some, via the NHS Trust, there are some sponsors posts for the masters where it's fully paid for, but in return, the arrangement is that you work for 2 years in the trust, and it's not for everyone. The thing that's been interesting is that a lot of people who've come through the scheme have gone on to get numbers, and it's an equivalent to core training, but I would still, if you are in core training, I'd recommend you do core training primarily on the basis that you just get a little bit more protected time for it. But if you're not in core training and you're an SHO level and you want to come through and work with us for 2 years in orthopedics, plastics, general surgery, and rotate through, then there's option to have a paid for MSc.
Cool.
Any other questions?
Great. Guys, if you're wondering why I'm standing in a shed, it's not really a shed, it's a container. I've taken the boy to play cricket, so I'm in the kit truck, or the kit container. That's all, because it was raining outside.
His wife has kicked him out of the house, and that's where he sleeps.
Right down the bottom of the garden.
Don't listen to him. Chris, I think if there's no more questions, how can people get in touch with us, Chris? How can they find out more?
If you email OrthoMasters, and let me put that obviously in the chat for you, at qmul.ac.uk, that's the best way. That I man that, not all hours of the day, sometimes feels like it, and anything appropriate for these guys, I'll obviously pass it on, but sort of the logistics and what to do and when and things, I can help you with that. There we go. OrthoMasters. Yep, I've got it right. Well done, me.
Yep. And so I would, if you have any questions about the application process, about eligibility, anything like that, Chris can answer all those, and is best placed. Similarly, you can find Peter and I on Twitter if you want to ask us anything. Thank you, David. David's obviously shared the page for the masters, which looks a lot more professional. Great.
Cool. Right.
If there's, I'll give you one last chance to ask a question. And if speak now, forever hold your breath. But if there's no questions, then thank you for joining us. Really appreciate you making the time. One thing I can guarantee you is if you leave this, by the time you finish this masters, you will know how to manage any orthopedic injury or traumatic injury with confidence. You'll be the most informed person in the room. You will know more than anyone in the room, including pretty much all the consultants, apart from the registrars who are sitting the exam that week. You will know more than everyone in the room. You'll be confident at dealing with the things in the day job. You will have enhanced your CV and your career to help your career prospects. And so, and also, I can guarantee you, you'll enjoy doing it.
Yep. Agreed.
Cool. Over now.
Cheers, Cash. Cheers, Chris. Thanks very much.
Bye, everyone.
Cheers, guys. Nice to meet you.